The American Brain Tumor Association is pleased to welcome you back to our webinar series. My name is Umbreen Maan, Program Manager here at the ABTA. Our webinar today is Know Your Tumor, Medulloblastoma. Today's webinar will be given in two parts. We will begin by exploring the pediatric medulloblastoma experience, after which we will learn more about medulloblastoma in adult patients. I am delighted to introduce our first speaker for the day, who will be discussing pediatric medulloblastoma. Dr. John Ruge has almost 30 years of experience treating both adults and children with brain tumors. He is Director of Pediatric Neurosurgery at Advocate Children's Hospital. He founded the Midwest Children's Brain Tumor Center in 1997 and serves as its director. He received his neurosurgical training at Northwestern University in Chicago. Thank you for joining us, Dr. Ruge. You may now begin.
Well, thank you, Umbreen, and thanks to ABTA for putting this on. It's a pleasure to talk to you about this very common pediatric brain tumor. Next. I don't have any disclosures or conflicts of interest. So I wanted to start by just kind of giving you the background on pediatric medulloblastomas and also who they affect and how they present. And we'll go through a couple real life situations and long-term follow-up. And we'll talk about some of the survivorship issues that are commonly occur with children with this condition. So, brain tumors are the most common solid tumor of childhood, second only to leukemia, and they're also the most common cause of cancer death is a brain tumor. The most common malignant brain tumor of childhood is the medulloblastoma, and there are about anywhere from 350 to 500 cases per year in the United States. They're usually in boys, and they're usually in that sort of under 10 age group. But we have the world's expert on adult medulloblastoma who will follow my talk to talk to you about the adult experience. So basically, it's a young boy is typical, but infants and people of all ages can be affected. Next slide. So what are the symptoms? Well, they're really age dependent, and they typically start with symptoms of hydrocephalus. This tumor in the back of the brain plugs up the spinal fluid pathways and generates this pressure with headaches being very characteristic. We looked at our series of children with brain tumors and tried to figure out what type of headache should alarm somebody, or was there something unique about the headache that would be a particular part? And one of the things that we found, the most significant thing, is headaches associated with vomiting is a red flag for sort of a distinct headache. Symptoms of cerebellar dysfunction, which is a cerebellum is your coordination center, both of your coordination of your arms and everything, but also your speech. And then brainstem or cranial nerve dysfunction, coordination, double vision, facial weakness. Each particular type of pediatric brain tumor presents with a different length of time of having symptoms before diagnosis. With the more malignant tumors typically presenting with a shorter period of time. And this, for medulloblastoma, typically it's 2 to 3 months of symptoms before it's figured out that someone has a tumor. Next. So survival is dramatically improved. If you had to look at all the brain tumors types, medulloblastomas are really sort of the poster child in how disease improvement has occurred with technology, radiation, craniospinal radiation, and chemotherapy. Next. So I want to talk give you a couple of cases that bring up several points that I think are important on medulloblastoma. This young boy I operated on when he was 5. He's 22 years old now, and we'll talk about his story. He started to have some speech difficulties, and they had what they thought was a Bell's palsy. And then fairly rapidly, over a couple of weeks, he was hiking in the woods a week or two before he was starting to have these very bad headaches, then with vomiting. Next. And he had this tumor, and you can see the blue arrows are pointing to the tumor in the back of the brain and extending forward into the cavernous sinus region. Next. he was metastatic disease. He also had tumor up and down his spine, which is not uncommon. We'll talk about subcategories of some of those medulloblastomas, but someplace in the 25 to 40% of individuals, depending on tumor type, will have metastatic disease at the time of presentation. In other words, scattered lesions in their nervous system. This is an older type of protocol because this is 15 years ago. And he was given fairly high dose of radiation to his craniospinal axis with 36 grade of his spine, and then boosted to some of the tumor nodules. And his treatment was completed in 2004. Next. So this is not unusual. He had a facial weakness and he couldn't close his eyes, so they did a tarsorrhaphy. He couldn't take feedings for a while. He had a G tube. In 2011, he underwent facial reanimation surgery in Toronto. He still has some weakness in that face. He's had cardiac ejection fraction problems from the radiation that was passing through to the heart, hearing loss from the chemotherapy, growth hormone deficiency, hypothyroid, osteopenia, kyphosis, and abnormal dental involvement. Next. He's now 22. I just saw him a couple weeks ago. He's happy. He says he doesn't have any problems or any complaints. Now, he can't read or write, but he is now going to complete his senior year in college in Iowa. When he's at Iowa, he lives on campus by himself independently, but he needs a scribe for all his writing, and all his books are audio. He has some balance problems, but ambulates independently. Next. And this is his MRI recently. You saw that the arrow's pointing to the empty spaces where the tumor used to be. Next. Again, no evidence of tumor now at age 22. Next. Next. This is now, he's now 11 years old. I operated on him when he was 5.5. He had progressive headaches over 9 days, and he had this characteristic arching of his back and screaming with pain. And a lot of these kids will present with pain and headaches back here. And I'll show you why, one of the reasons we think why. He's sleeping more than usual, and just before diagnosis, he's starting to veer to the right when he walks, some imbalance problems. Next. And here's his tumor, located in between the arrows. And if you look down at the bottom of the brain, you can see how the brain is sort of sticking out into the neck with an acquired Chiari malformation. And some kids arch their neck like this. It gives them a little bit more room. And a lot of people present with some neck pain from this tumor causing that pressure. Next. The tumor is, when you give enhancement or the gadolinium, it can have a heterogeneous enhancement pattern, as you see here. And that top arrow shows how this tumors, normally this tumor is confined to the back of the brain, but sometimes they get so big they poke up into the top part of the brain. Next. And here you can see the tumor poking up from the bottom part in the infratentorial through the tentorium into the supratentorial space. Next. So he underwent a newer therapy, and this is a fairly standard therapy now for children, reduced spinal radiation, and the use of proton therapy. The proton therapy has tremendously helped spare adjacent tissue. You know, photons, which is like the standard radiation, the radiation goes right through, and you have a little bit of low dose radiation exposure to adjacent organs like the heart, the GI system when you do the spine. And the heart and the GI system get zero radiation now with protons. So this is a huge improvement with the use of protons, and also reduced dose radiation to now 23.45 grade of the spine. Next, it should be mentioned that radiation is one of the biggest advances in medulloblastoma. Before they gave radiation, hardly anyone survived. And then soon in the early 60s, radiation addition had boosted survival to 60%. Now, it's also the major problem with toxicity. The long-term side effects usually come from the radiation exposure. So we'll talk more about that. And here you can see that now he doesn't have any tumor. This is a recent study. Next. no evidence of tumor with him. And next, he's had problems. You know, this is a aggressive treatment, right? Ulcerative skin rash, hearing loss, growth hormone deficiency, fine motor issues, neuropathy. He's 15 years old. He'll be a sophomore in high school this year. He reads at a 5th grade level, has short-term and working memory problems, but when you see him in the clinic, he's a delight, and you know, just kind of casually, I don't think anyone would think that he had any issues, but he does. Next. The last case I want to present is a 4-year-old male who's now 11. And he presented with another way to present with this, which is several months, 4 to 6 months of intermittent vomiting, nausea, vomiting. They couldn't figure out. They thought it was GI type of a situation. And he didn't have any headaches originally. And then he started to have just neck pain without headaches, and then started developing the balance and gait issues. So this is another way that, and you can understand why it would present that way based on some of the anatomy that we in the back of the brain. Next, and here's his tumor filling up the 4th ventricle, and you can see the little black round things on the side of the ventricles, these hydrocephalus. Next. And again, the arrow's pointing down to the bottom of the brain, showing that acquired Chiari-2 malformation, which is the brain being pushed down, and this can be fatal if this is if he's not taken care of quickly. Next. Here again, the tumor in a cross section going out into cerebral-pontine angle, and this is with enhancement, so you can see it's sort of a heterogeneous enhancement pattern, again, like many medulloblastomas. Next. Again, the tumor, as you can see in the back of his brain. Next. He underwent, again, the limited radiation, and the improvement in some of the radiation treatment is used to do the entire back of the brain, do the total posterior fossa. And now they're doing sort of targeted or limited or reduced dose. So in other words, just the tumor bed, and sparing some of as much of the brain as possible with the higher dose things. He presents with an interesting problem that up to 25% of people who have this surgery and medulloblastoma have, which is a posterior fossa syndrome, of mutism. So he woke up after surgery, and within a day or two, he couldn't say a word. He could understand you, but he could not speak. He was mute. And this is not that unusual, unfortunately. It can last several months. His last several weeks, and slowly got better. We used to tell everyone that everyone will get 100% better. It may take time, it may take months, it may take a year. And in general, that's the case, although nothing's 100%. Fourth nerve palsy, ataxia, cataracts, again, the radiation exposure to the eyes, hypothyroid, growth hormone deficiency. Next. Here's this now, he's tumor-free. Next. Again, tumor-free. Next. He's 11 years old, and just a couple of weeks ago, he started to ride his bike because of the balance issue. The mom has got him in a martial arts program, and his track, he's doing so great, he anticipated black belt in May of next year. He's in 5th grade, doing well. He's got a 1-to-1 aid in writing. He has some thoughts processing slow, but again, is doing very well. Next. So that kind of gives you a little feel of the different and how some of the follow-up issues are with these children. The neurosurgical management I won't delve into, but it's two things. It's a tumor, it's a hydrocephalus. Typically, they're treated at the same time with an external ventricular drain put in, a little tube, and then typically you can take that out, just slips out like an IV. In those cases where it doesn't, we'll look into doing an endoscopic third ventriculostomy, and sometimes that's successful. At what cost should you go to remove every little bit of tumor? Well, this is the one tumor that you should get as much out as possible without hurting the person. So the studies have all showed 1.5 cubic centimeters of tumor is kind of which is like a sugar cube, a little bit bigger than a sugar cube full of residual tumor. If you leave that amount or less, the individuals in the studies do just as good as if you left nothing. So you tried to leave nothing, and I've in intraoperative MRI, the first case we brought the child back, there was a little too much residual. I brought him back and did a intraoperative MRI resection that helped. And tumor died. We've got a new study that's about to roll out later this year, probably next year, with Mount Sinai, looking at 5-ALA. Can we give some dye to medulloblastoma patients so that we can see tumor and distinguish it from brain, so that we can get even a safer resection and more tumor out? So I'm excited about that study, and you'll hear more about that later, hopefully, in the ensuing months. Next. This is unique, and that's why I wanted to highlight it, the posterior fossa syndrome, cerebellar mutism. It's not unique to medulloblastoma, but it occurs up to 24%. It occurs in tumors located in that region, and can severely affect individuals where they have emotional lability, attention deficit issues, and it has to do with disruption of the fibers from, as you go in to remove the tumor to get at it, typically those fibers are disrupted, or the tumor itself disrupts those fibers. It's actually quite amazing that they reconnect, and this is a problem that typically goes away. It can be quite disturbing, obviously. Next. So, this tumor has come a long ways. It's come where, you would classify these tumors based on what they look like under the microscope. And there's less reliance on that. Two tumors now can look alike but behave very differently. And that's been a huge advance in the treatment of pediatric brain tumors, and I think in neuro-oncology throughout, is looking at how they behave rather than how they look. And the molecular classification is advancing care and treatment, and it's really exciting. There's some really exciting new stuff going on here. And next slide. So in 2016, WHO recognized these 4 distinct classifications of medulloblastoma, and I'll briefly touch on them, and I know Marta is going to touch on them a little more as well. But wingless is a separate type. It's the wingless integrated type of a tumor type, the sonic hedgehog tumor types, the group 3 and a group 4. If you look at these groups, the wingless is the best prognosis. And the worst prognosis right now, about 25% of the tumors, unfortunately, are in the group 3, the sonic hedgehog activated with the TP53 mutant tumors. That's where a lot of work needs to be done. The sonic hedgehog, typically are younger kids, the infants under 3. The group 4 often are metastatic at the time of presentation. The wingless are typically the older, like the 10-year-olds and the young adolescents, and not metastatic at presentation. Next. So this makes a huge difference. We used to, so the kids I presented were typically treated based on what they look like, the nodular. There's different ways of classifying medulloblastomas just based on how they look, and then categorizing them into risk criteria. If you're under the age of 3 and you have you're in a separate risk group, if you have metastasis and residual tumor, you're in a high risk group. But now this all shatters all that. This goes into a whole different way of classifying these tumors. So that if you're in the wingless group and you get the radiation and chemo, your survival, some of them quoting series up to 100% 5-year survivals. Now we'll talk a little bit more of that, because even though you can survive 5 years, what's the 20-year survival? What's the 40-year survival rate? And that's where we start to get into survivorship issues, where you can still have life-threatening problems even though you're cured of your tumor. The sonic hedgehog is an interesting tumor because there's some targeted agents using the smoothing pathways that are being tried and with some exciting results. The group 3 and a group 4, as mentioned, the group 3 is the worst prognosis right now. Next. One of the things you'll see as you go to look at, or your physician, your oncologist will go to clinicaltrials.gov and look at some, there's a lot of neat trials going on. If you look down this list, if you put in medulloblastoma into this website to see what trials are available, you'll see them broken down to the medulloblastoma wingless, which is a WNT activated, and then you go down a few more non-wingless, sonic hedgehog, that's a group 3. And a lot of efforts going on right now to try to de-escalate the treatment exposure of the wingless group, and to reduce the radiation even more, reduce the chemotherapy even more in these really good prognosis category, because the radiation is where, in some of the high-dose chemotherapy, is where the long-term problems happen. Next. So kids, thank God, are living longer, and part of this is better medical care for the late effects of therapy. Next. 75 to 80% of medulloblastoma patients, survivors, will experience late effects, and they can be severe. And this is very important. Next. And this is a challenge. So because the therapies can affect lots of different things depending on how old you are. And so, you know, they just stopped one of the targeted studies because it stopped bone growth in kids. And so each therapy has its own issues, even some of the sort of the newer modern ones are looking at. But there's no question that radiation is one of the biggest factors in long-term survivorship issues with these individuals. Next. So the cure comes with a price, and if any of you have had medulloblastoma or watching, you know what that price is. And every exposure you've had, chemotherapy, surgery, or radiation, can cause problems. Next. How do you get at this? What do you do if you're a survivor, thank God, but and you're wondering about what should you do? What should be checked out? Well, the Children's Oncology Group's got a great website, a great long-term follow-up guidelines. Next. And they really break it down. If you go to this www.survivorshipguidelines.org, it's a 235-page manual that breaks down, like, where was your radiation given to you? Then you have to worry about this. What was the chemotherapy drug that you had? You have to worry about that. Next. And this is, you can't read all these little things, but I put it on there just to show you how detailed it is. For each drug that you have, that you've given or been exposed to, they now know what to look for. It's not just the hearing, audiograms, but it's also hormonal and other sort of different secondary cancers that can arise, thyroid cancer being one of them, and so forth. Next. So that's with radiation, and then the chemotherapy is broken down into each of the different agents that were and what you can expect. Pulmonary fibrosis, renal toxicity, ototoxicity, cisplatin, and plant alkaloids have been crystine and so forth. Next. So how do we, what do you do with children? These kids, I've been doing this for 30 years, and now these kids are 30 years, some of them are 30 years out. Well, the basic thing is that every year for the rest of your life, you need to be evaluated for these possible problems. And there's really a science developed behind this. The Pediatric Oncology Survivors in Transition, we have in most places we'll have a survivorship specialist that their full job is to look into what did you have exactly, what are you at risk for, did you get those tests done, do you need to see an endocrinologist, do you need to see a neuropsychologist or whatnot. Next. So if you've had a medulloblastoma, the most important takeaway message I think from this, excuse me, from my talk, excuse me, is to make sure you get a medical checkup once a year. And if your doctor, your regular doctor, is not familiar with the brain tumor survivorship, seek out a program near you, or you know, bring this the survivorship guidelines. It's a little hard to navigate for the patient. It's a very complicated sort of a guideline thing, but the physician should be comfortable with it, or the program you're in. And the other thing is that there are many exciting new trials on the horizon, or underway actually, reducing the toxicities of these therapies and still trying to keep the strong and improving on survivors, the number of people who survive. So with that, thanks for your attention, and I'll turn it over to one of the world's experts in medulloblastoma. Thank you.
Thank you so much, Dr. Ruge. Our next speaker today is Dr. Marta Penas-Prado. Dr. Penas-Prado is a practicing neuro-oncologist focused on caring for patients with rare brain and spine tumors. She leads the NCI Connect Clinic for adult patients with rare CNS tumors at the Neuro-Oncology branch of the NIH. Dr. Penas-Prado's areas of expertise are in adult medulloblastoma, epidemiology, rare CNS tumors, and clinical trials. Thank you for joining us, Dr. Penas-Prado. You may now begin your presentation.
Thank you, Amreen, and thank you so much to the ABTA for inviting me to be here today. Next slide. I'm going to discuss briefly an experimental medication in one of the slides towards the end of my presentation. Otherwise, I don't have any disclosures. Next slide. So you've heard from Dr. Ruge about medulloblastoma in children. So what I'm going to do next is to try to highlight some of the major differences between adult medulloblastoma and childhood medulloblastoma. And on this first part of my talk, I'm going to highlight the differences of medulloblastoma with another brain tumor that happens in adults, the most frequent one called glioblastoma. Next slide. So on the next several slides, we will look at the main characteristics of glioblastomas from now on GBM compared to medulloblastomas, MB on the slides. Next slide. So glioblastomas and medulloblastomas are both considered malignant tumors or grade 4 tumors according to the World Health Organization classification, but they have many differences. And I wanted to highlight it this way because, of course, even though primary brain tumors are rare, glioblastoma tends to be on the news a little bit more. So you may be familiar with some of the facts related to glioblastoma, and I think it'll help to remember more about medulloblastoma if we compare them side to side. So if we look, for example, at the age when glioblastomas and medulloblastomas appear and the number of cases that happen every year, we can see very interesting differences. So on the left side of the slide, we see glioblastomas. Next. And we see that a peak of the number of cases happens in later stages of life towards age 70 and around that age, both in men and in women. Next slide. Next slide. And when we look at medulloblastoma, this graph actually is representing multiple different tumor types. It's from a publication that looks into the incidence of rare CNS tumors, a number of them. But if you look at next, the arrow that will show on the slide, you can see the line that corresponds to medulloblastoma. It's an orange line that starts and then goes down and down. And it's telling you that medulloblastoma is much more frequent in children, but it does happen in adults as well, and predominantly in young adults between the ages of 15, this is late teenagers, and 40. Next slide. What about where the tumor is located and how it looks like on an MRI? Glioblastoma has a very typical picture. If you've ever seen an MRI, you will immediately realize that there's something going on the right side of the head, and it's actually the left side of the slide. And you can see an arrow pointing towards an area of the brain that shows something that looks white. We call that contrast enhancement. And there's some darker space inside that is called necrosis. Next slide. So we can see on the right an imaging of a medulloblastoma. And the important point is, number one, medulloblastoma can look very variably in MRIs. Depending on the case, depending on the molecular features of the tumor, we can see different imaging appearances and not necessarily a whole lot of enhancement with contrast. So these tumors can sometimes be difficult to detect. On the right side of this slide, we see on the left and an orange arrow is pointing towards a tumor, which is after giving contrast, and you can notice that you can barely see any brightness going on that slide. And on the right side, you can see a scan without contrast, and on that scan you can see it much better. So other tumors have actually more contrast than others. All of them are going to be located, though, originally in the cerebellum, the back part of the brain. Glioblastomas can appear in other parts of the brain, sometimes in the temporal lobes, like this case you see on the slide, or on the frontal lobes, or other parts more superiorly in the brain, and medulloblastoma always in the back. Next slide. Another important point is what we call a staging. Staging basically means the testing we do to detect a spread of tumors. The glioblastomas, patients with glioblastoma usually do not need testing to detect if the tumor has spread to other organs, because generally they don't. They usually spread to the same area of the brain or some other areas of the brain. That's more common, but they less commonly can spread to the fluid around the brain and the spine, and very, very rarely they go outside of the nervous system. So next. We usually don't do staging as part of routine care. Next. Next. In medulloblastomas, however, spread to other areas of the brain, spine, or the fluid, or outside the nervous system is possible, and Dr. Ruge already mentioned that. This happens more frequently in children at diagnosis, as he said, maybe up to 30% of children with medulloblastoma can have dissemination or presentation. In adults, this is less common, but it can happen. And it definitely happens if the tumor comes back. In these cases where the tumor comes back, we can see with certain frequency that the tumor has been able to find a way to spread to other parts of the brain, the spine, the fluid, or even other organs. So for this reason, it's part of routine care for patients with medulloblastoma to get MRIs of the brain, the spine, spinal tap, and sometimes other tests as decided by your doctor, like a CT of the body. Next slide. So based on this staging is that we classify medulloblastomas in two different groups. One is standard risk and the other is high risk. And basically a standard risk classification means that there's been a complete resection of the tumor after surgery, and all these tests have not been able to detect any spread. However, if we consider a situation high risk, that means that there has been an incomplete resection after surgery, or there is a spread of the tumor to other parts of the nervous system or outside. And how does this help us, this deciding if a specific situation is a standard risk or high risk? Well, basically that's telling us what to expect. How likely is this tumor to get sort of reactivated? How aggressively it's going to behave? And it helps us decide the type of treatment. That's what this classification is for. Next slide. So Dr. Ruge also touched on this. What is pathology? Pathology means how the tumor looks under the microscope. Once we take a sample during surgery, we send it to our colleagues, the neuropathologists, and they look at it. And glioblastomas have very, very typical features most of the times. We have a picture here that shows a specific feature of glioblastomas that is called pseudopalisading necrosis. So they are usually very consistent. It's for expert neuropathologists, it's easy to identify a glioblastoma most of the times. Next slide. In medulloblastoma, however, things get a little bit more complicated. We can see actually different variants. There are these 4 described: classic, desmoplastic of nodular, extensive nodularity, and large cell of anaplastic. And these are different variants that are not necessarily clearly linked to prognosis or clearly linked to what treatment to use, although there are some associations. This is a bit complex to get into, but if any of you has questions later, I'm happy to answer them. What is important to understand is that today we have additional testing that is incredibly helpful to pinpoint a little better what type of tumor, what type of medulloblastoma variant we are talking about. And these are tests that we call gene sequencing and DNA methylation, and others like some tests that we call immunohistochemistry techniques. So all these techniques help us to classify medulloblastomas in different subgroups. Next slide. So in glioblastoma, when we do this type of testing like gene sequencing, there's one gene that stands out, it's called IDH, and based on that we classify glioblastomas on IDH mutated or wild type, that means basically not mutated. Next. In medulloblastoma, when we do this type of testing, as we said, there are different techniques that can be used. We can classify them in 3 major groups, as Dr. Ruge said earlier: the Wnt activated, the sonic activated, and the non-Wnt non-sonic, which actually includes 2 subtypes, group 3 and group 4. And we'll see a bit later how these groups look like in adults, because the distribution of the groups is a bit different than in children. Next slide. What about radiation? You may have heard that patients with brain tumors, of course, are commonly treated with radiation. You've also heard that from Dr. Ruge. And there's a very, very important difference in here. In glioblastoma, the radiation is usually given to the place of the brain where the tumor was located and some margin around it. And that's called involved field. And you can see on the screen some colored areas in pink and in blue that are telling you where the radiation was given in the brain. Next. In medulloblastoma, however, radiation is given more extensively and not only to the place where the tumor was located. And why is this? Well, this is because, as we said, this tumor has a very, very high tendency to disseminate into other parts of the brain and even the spine. So what you see in there is a representation of the radiation field. It's called craniospinal, and that means that it involves not only the place where the tumor was, but also the rest of the brain and the spine. So we have to cover all that, and we call that craniospinal radiation. And there are different doses that are given. That's also a bit more complex, and if there are questions about that, we can talk about that at the end. Next slide. So what about chemotherapy? Does chemotherapy have a role for medulloblastoma, and specifically in adults? The answer is yes. But the chemotherapies that are used are quite different than the chemotherapies used in glioblastoma. You may have heard about this chemotherapy called temozolomide or Temodar that is used all the time for glioblastoma. It's part of the standard of care and is used up front when the tumor is diagnosed, during and after radiation, immediately after, and that is called concurrent and adjuvant. And glioblastoma, unfortunately, tends to come back quite often in many patients. And when the tumor comes back, there are some other chemotherapies that can be given. Sometimes we use combinations, but oftentimes we use these chemotherapies alone without combining them among them. And there are, of course, also experimental trials and drugs that are being tested to improve the outcome of these patients. Next. In medulloblastoma, however, the way chemotherapy is used is a bit different. We use combinations of chemotherapy. For patients who are newly diagnosed, we typically use a combination of medications, as you see on the slides, that can include cisplatin, lomustine, vincristine, or cisplatin, cyclophosphamide, vincristine, and others. But those are some of the most frequently used. And the important point is some of these medications are IV medications, actually most of them, except lomustine, which is oral. So that means this is a medications that are given IV as opposed to the oral medication that is used in glioblastoma, temozolomide. So, and these medications tend to be quite likely to cause side effects. So this is a treatment that tends to be difficult for some people. And it is incredibly important to have a very, a deep discussion with your physician if you're diagnosed with medulloblastoma to decide how to use these medications and when to use them. We do have evidence that chemotherapy helps adults the same as it helps children. But a very important point to keep in mind is that these type of chemotherapies in adults tend to be more difficult on them than on children. And you would think, wow, that's amazing how that happen. You know, children, we tend to think about them as, you know, more sensitive to these treatments, but their body is young, tends to bounce back much more easily than the body of an adult. And for that reason, these chemotherapies can be a bit tricky to use, but they definitely have a role, and it's important to have a discussion with your physician. For recurrent tumors, when these tumors, and if these tumors come back, not all of them do, actually many of them don't, but some do. When they do come back, sometimes we use similar combinations of chemotherapy. Interestingly, temozolomide can also be used sometimes, can also have a role for some people. And importantly, at the end of the slide, I mentioned experimental medications, and I mentioned specifically a group of medications called smoothing inhibitors, SMO inhibitors. The most well-known are two medications called vismodegib and sonidegib, and they are approved for other indications in head and neck cancer. And these medications have been tested in clinical trials for a type of medulloblastoma called sonic hedgehog that you've heard before from Dr. Ruge. And it seems to they have some effect on recurrent tumors. The effect tends to be transient. Many of these tumors are able to find a way to resist the effect of treatment, but these are very important medications and they are still being tested in trials, as we will see at the end of the talk. Next slide. What about survival? So on this graph that you see on the left, this is glioblastoma, and you see on the x-axis, you see ages from the younger to the oldest. And even though these tumors are more frequent in people in their 70s, you can see that can happen at any age. On the y-axis on the left, you can see the proportion of people that survive the disease 5 years down the road. This is how in oncology typically we measure survival. And you can see that the younger people do better than the older people. Next. On medulloblastoma, actually the prognosis varies depending on that risk stratification and other factors, but we can see how the possibilities of long-term survival and even a cure are much, much higher than in glioblastoma. We have to treat these tumors much more aggressively, but there's also a much higher chance of survival at 5 years down the road and later. And that survival is higher on people with a standard risk than with high-risk tumors. Next slide. Importantly, remember always these are only statistics and every person is unique, no matter what tumor they have, no matter what risk stratification they have, every person is going to be unique. And there's no tool to predict upfront what the survival of a given person is going to be. That's only something we can tell when looking back. Next slide. So on this second part, we're going to talk briefly about some major differences between adult medulloblastoma and children medulloblastoma. Next slide. And this figure summarizes quite well what has happened over the last several decades. You can see a balance, you can see a kid on the right, you can see an adult on the left. And what you see is that the balance is moving towards the kid. Why is this? Because there's been a lot more research done for pediatric medulloblastoma than for adults, because adults with medulloblastoma are much, much less common and it's been much more difficult to perform research. Next. So the frequency in children is 10 per 1 million. And that boils down to about 450, 500 new cases per year in the United States. Next. In adults, medulloblastoma is less than 1% of brain tumors, and the frequency is about 1 per 1 million. But still, medulloblastoma in adults is about 30% of all medulloblastoma cases. And if you count all the cases that are diagnosed in the United States and in Europe, for example, you can see how the numbers add up. And the take-home message here is that collaboration is key to be able to make progress. Next slide. This slide also summarizes several important points. Again, adult medulloblastoma is very uncommon, low incidence. Long survival is definitely possible, and cure is possible. But in adults, sometimes the tumor can come back much later than in children. In children, most of the times the tumor, if it's going to come back, it's going to come back maybe within the first couple of years, the first 3 years. In adults, sometimes that can happen as late as 3 or 8 years down the road. So it's important to keep surveillance basically for the rest of the life. And as we said earlier, there's a very high chance of long-term survivorship or even cure, but that does not mean that we are completely out of trouble, because unfortunately many patients that are long-term survivors from this disease and others, they also have important sequelae from the tumor and from treatment, and that may lead to reduced quality of life. So we as physicians, as healthcare providers, are paying a lot more attention to these issues these days. There's very little we know about survivorship issues in medulloblastoma in adults, but we are definitely paying attention to that and trying to learn more to help people with this problem. Then, of course, there's also a number of people in whom, unfortunately, the tumor will find its way back. And it is very difficult to predict who these patients are going to be. We spoke about the high-risk group and how people who have disseminated disease, metastatic disease at diagnosis, tend to have a higher chance of having the tumor return. But sometimes the tumor is able to find its way back in a way that we are not able to predict upfront. So that's another area of intensive research where we have to dedicate the next years to try to understand why some people who don't have the typical clinical factors that would indicate an early recurrence, they have recurrence of the tumor. Next slide. This is a slide to summarize the differences between the molecular groups. You can see two pictures on the top, on the left side. You can see a group of adults and you can see a group of children. And if you look at the group of children, you can see that group 4 is the most frequent. It's followed by group 3 in yellow, then sonic in red, and then wind in blue. In adults, that changes a little bit. The most frequent by far is sonic. Next. We can see that is up to 70% of adults have actually sonic medulloblastoma. Group 3 in adults is exceptional, is very rare. Next. Wind is perhaps a bit less frequent. It's a bit unclear whether it's about the same. In any case, less frequent than sonic and group 4. And finally, group 4 is the second in frequency in adults. There are some other important differences that involve prognosis. We heard from Dr. Ruge that wind tumors in children have very, very good prognosis, and current clinical trials are actually trying to decrease the amount of treatment that these patients receive. In adults, it's slightly less clear. We are paying attention to try to understand this better, because it seems like some of these wind tumors in adults actually are able to find their way back more easily than in adults. So we are more cautious when thinking about decreasing the amount of therapy. We are a lot more cautious with them. Next slide. This is a complicated slide that actually the take-home message is things are not so simple as we mentioned so far. There are probably far more groups of medulloblastoma. You can see here a publication where they describe up to 12 subtypes of medulloblastoma with 2 different wind subtypes, 4 different sonic, 3 group 3, and 3 group 4. So things are getting more complicated, but also incredibly exciting, because the more we learn about medulloblastoma, the more we learn about possible ways to tackle the tumor and treat it much better. Next slide. And now finally, to finalize my talk, I'm going to touch briefly on future directions and things that we're trying to do to improve the outcome and research for adult patients with medulloblastoma. Next. So this is happening in a much broader context of the challenges of rare central nervous system tumors. There are many, both from the point of view of patients and the point of view of research, and they are on the slide. We don't need to spend that much time looking at them, but I'm just going to read a couple of them on top. For patients, long time to diagnose, cancer might be identified at advanced stage. Sometimes there's not a clear standard of care. And for researchers, it's very difficult to design trials for small populations. There are very, very few models in the lab that can help us understand the disease better and develop new therapies and so forth. Next. So based on this, we recognize the need to develop a network and collaborate with different people, patients, healthcare providers, patient advocates, to try to improve this situation for patients with rare CNS tumors. Next slide. And in this context, Mark Gilbert, a deputy chair at the Neuro-Oncology branch, and Terry Armstrong, deputy chief at the Neuro-Oncology branch at the NCI, started this program in 2017 called NCI Connect, that is specifically dedicated to help improve the outcome of patients with rare CNS tumors, including medulloblastoma. And I was fortunate to join the program a couple of years ago. Next slide. So one of the features of the program is a very strong focus on education. And if you enter our website, you will see that you'll find information about medulloblastoma. Next slide. Including, for example, information about the incidence, the frequency of this tumor, and even testimonies from patients. And this is for all rare CNS tumors, but I want to let you know that medulloblastoma is also in there if you want to learn more information. Next slide. Very importantly also, we dedicate scientific workshops to different rare CNS tumors. And you can see on the right side of the slide, the list of workshops we celebrated so far. And you can also see that in November last year, we had a workshop dedicated to adult medulloblastoma. Basically, what we did in there was to gather multiple experts from around the world, patient advocates, and we sat together to analyze gaps in knowledge, problems in research, problems in patient care, and try to design a plan to find solutions. And next, as a result of that workshop, we actually just published a paper that summarizes what we discussed at the workshop and next step to try to expedite progress for adult medulloblastoma. Next slide. Oftentimes we hear from our patients with medulloblastoma that they feel alone. They find information about medulloblastoma in children. They find maybe support groups for children with medulloblastoma and their parents, but there's not so much information out there for adults. And the same also for other patients with rare CNS tumors. And to try to help with that, the NCI Connect program at the NCI has different tools. We have developed different tools that help patients have more meaningful connections and get more information about their disease. So you can see different resources in there, like our website. We have also a newsletter that you can subscribe to. You can follow us on Twitter. You can even join a closed Facebook group. And you can see also the contact information for the program on the slide. Next. The ABTA has also very, very interesting resources for patients with medulloblastoma, such as a medulloblastoma brochure that recently we collaborated on updating, adding some information about adult medulloblastoma, as well as educational webinars like the one you're watching now and others. And they have also a phone line called Care Line where you can call to get orientation about different topics. So don't hesitate to use all these resources to try to get some more help. Next slide. And just to finalize, I want to highlight the very important role that clinical trials have to advance the field for both childhood medulloblastoma and adult medulloblastoma. And just as an example, I wanted to mention this is a clinical trial that we have currently ongoing at the NCI, and it's using an immunotherapy treatment called nivolumab for the treatment of rare CNS cancers, and that includes medulloblastoma. Next slide. And very importantly, I want to finalize by mentioning two clinical trials that are being designed for newly diagnosed adults with medulloblastoma. And we're not going to get into the design because it's complex, but there's two initiatives, one led by Dr. Peter Howe in Europe and led by the EORTC consortium. And then next, another initiative led by Dr. Anita Mahayan and the Alliance on Clinical Trials in Oncology. And both trials basically are going to be enrolling newly diagnosed patients with medulloblastoma, with the main goal of determining if those medicines that I mentioned earlier in my talk, the movement inhibitors, if they have a role when they are used upfront with initial therapy, when someone is just diagnosed, has surgery, and is starting radiation and chemotherapy, when we add these medications right there. So these trials are about to be a reality, probably within this next year, and we'll start enrolling patients, and hopefully will help us to have a much better understanding of medulloblastoma in adults. Next slide. Just a few conclusions to close my talk. Medulloblastoma is less common in adults. The genetic alterations in tumors are different. The tolerance of adults to treatment is also different. And same as in children, adults are treated with craniosspinal radiation and chemotherapy, but the treatment plan must be individualized because treatment is also associated with toxicities. And finally, I want to send a message of hope. There is increased awareness of the special needs of adults with medulloblastoma and ongoing initiatives to improve their care, including new clinical trials. Thank you so much for your attention.
Thank you so much, Dr. Penas-Prado, and Dr. Ruge as well for your wonderful presentations and insight. We now have some time for questions. Remember, if you do have a question that you'd like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen, and we will answer questions as time allows. So the first question we have here, Dr. Ruge, this is directed to you. You talked a lot about some of the late effects that long-term pediatric patients and survivors may experience. And you mentioned, effects in the eyes, fertility, things like that. One of our viewers here is asking, is deafness also a common side effect from medulloblastoma radiation and treatment?
Yes, so hearing loss, the cisplatin is one of the agents that is characteristically attributed to causing hearing loss. So kids are followed very closely with audiograms, and some kids require sophisticated hearing support.
And Dr. Penas-Prado, have you experienced effects in hearing with your adult patients as well?
Yes, it's definitely possible. Cisplatin can also cause hearing loss in adults, and if anything, they may be even a bit more sensitive. So it's very important to monitor. So the dose can be reduced or stopped, or maybe changed to a different medication with a bit less effects on hearing. It's a very important point.
Thank you. Now, also on the topic of side effects, are you aware of any targeted therapies or advancements that can help minimize some of these late effects, or are there any proactive actions that patients and families can be taking to help manage or potentially prevent some of these side effects? Dr. Ruge, we'll start with you, and then Dr. Penas-Prado, please feel free to jump in.
Well, that's an excellent question, and that's really the focus. Some of these treatments, especially with the WNT, the wingless group, are having tremendous long-term survival and so forth, and so they're trying to de-escalate the therapies. A lot of studies are ongoing now. One study even is with no radiation therapy at all, but you have to have very specific markers to make sure you're in that category that can tolerate that. So the answer, the first part of the question is yes. I think there's a huge focus on reducing toxicity now that we have long-term survivors and we're seeing the effects of the long-term problems. What to do to prevent that? I think it's really important to have good medical care, to be at a place that's familiar with survivorship, and to also then, of course, take good care of yourself with exercise, immune, and stuff that keeps your immune healthy, eating, healthy habits, sleeping cycles, and so forth. But you need a professional as well to do some blood tests, make sure your thyroid is a very common organ that's affected with the radiation side effects, and something that can kind of hide in the background unless you get some medical tests to know about it.
Dr. Penas-Prado, did you have any advice that you'd like to share as well?
So very similar response. Actually, what I want to say is that we know a lot less in adults about survivorship issues, and we really want to learn from patients who are going through this experience. So here at the NCI, we have programs dedicated to actually understand the patient's experience, and we think it's critical to understand what's happening to them so we can start implementing these measures to help them. But what Dr. Ruge mentioned about finding a specialized care, taking care of yourself, trying to stay healthy otherwise is always going to be very helpful. But we also must recognize we have to learn more about these issues so we can find ways to solve them and prevent them.
Wonderful, thank you. And this next question, Dr. Penas-Prado, is for you. You talked a lot about clinical trials that you've been working on. Do you have advice on how patients and families can talk to their medical team about clinical trials, potentially getting on one, finding one that they might be suitable for?
Yes. So finding clinical trials is incredibly challenging. It's even challenging sometimes for us as healthcare providers because it's a complicated topic and it's difficult sometimes to know what clinical trials are available or open or appropriate for a given patient. So the first step is always to speak with your physician. Your physician and your healthcare team in general have resources that they can use to try to look around and ask the experts and try to see if there's a specific clinical trial at an academic center or some other place close to where you are. And we must recognize that this brings an additional challenges because traveling frequently to another center to get care can be incredibly challenging. And I think that we have all learned over the last several months how the situation that we are going through together, this pandemic, has involved, induced changes to the way we practice sometimes. And we hope that this will impact also the way that we conduct clinical trials in the future. It's still early to tell, but we're hoping for positive changes that increase participation to trials.
Great. And this next question I'm going to direct to both of you. So Dr. Ruge, we'll start with you, and then Dr. Penas-Prado, please feel free to jump in. So on the topic of clinical trials as well and just future options for patients, both of you talked a lot about chemo, surgery, radiation. Can you talk about immunotherapies? Is that something that's effective in medulloblastoma, both for children and adults?
That's a good question, and it was just presented, I think, in Dr. Penas-Prado has the trial that was out there. But there are a couple. There's one trial that I saw at our last meeting where they used low-dose radiation, very low-dose radiation to sensitize the tumor and heighten the immune response and for medulloblastoma. And it's so yes, there are some immunotherapies that show some potential, but in very experimental phase right now.
Yeah, I would say the same thing. It's the role is clearly only experimental at this time. We don't have a sense that any specific immunotherapy or cell therapy, which basically means using the own immune cells of the body to fight against tumors. We don't have any evidence that they work against medulloblastoma or actually against any primary brain tumors. But the important point is there's an incredible amount of interest on developing this area further, and there are clinical trials. I would encourage people to look into potentially participating on trials if they have the opportunity and if they feel comfortable with this type of options.
Great, thank you. This next question is for you, Dr. Ruge. With the treatments that you mentioned that many children, pediatric patients go through, and the side effects that they can cause at an early age as well as later in life, would these side effects, do you see it also having an impact on the patient's mental health and well-being as well? Have you seen a lot of patients developing issues like anxiety or depressions as they enter adulthood due to those treatments and what they went through as a child?
Yeah, that's very common, unfortunately. So there's a couple issues. One is that the radiation itself can cause neurocognitive problems itself. But then there's, of course, the reaction to having these disabilities and and also coping with the whole stress of these, the therapies and other things that they've been exposed to. So I think it's very important to have a multidisciplinary team of social workers. We have, and most places have, support services that interact with the school system to make sure that the adaptations are necessary, that the children are being reintroduced to the school right after surgery in a nice way, and also that they get the necessary emotional support and whatever therapies they need as well. Very important.
Great. And similarly, Dr. Penas-Prado, we have a question here asking about, adult medulloblastoma patients. You briefly touched on this as well, where they can often feel isolated because so many other patients their age are dealing with completely different brain tumors, different experiences. They have a hard time connecting when they attend a support group or they're in the clinic, for example. Do you have any advice on how adult medulloblastoma patients can connect with others or find some of that social support so they don't feel so isolated?
Absolutely, yeah, that's a huge problem. Thankfully, we live in a world now where social media is easily reachable for almost everybody, at least in our environment. And there are certainly resources out there. I mentioned a few that we coordinate from the NCI Connect program. And it's a way to get in contact with people that may not be in your neighborhood, certainly, maybe not even in your country. But nevertheless, social media has this beautiful power of bringing people together, and you can actually get in contact and know other people going through a similar situation that way. We also have in our center a specific clinic dedicated to people with rare CNS tumors, where we bring them together on the same day to participate on similar activities and come to clinic. Unfortunately, these days, the activity of that clinic has been on hold for some time due again to the pandemic. But once we go back to normal clinical operations, we'll have that clinic going on again. And what we do is to bring people with these initial tumors, again, to bring them the opportunity of not only seeing us to coordinate their care, but also to meet each other and get to know the people going through similar life experiences.
That's great. And I do just want to share on that note a resource that's available through the ABTA for anyone who is looking to connect with others who are going through very similar experiences. The ABTA does offer a free peer-to-peer mentoring program through which you can connect with your own mentor who's a volunteer that's gone through very similar diagnosis and experience as yourself. So please check out abta.org for more information on that or to get connected if you were interested. So just going through some of these questions. Dr. Ruge, you had talked about Optune and using Optune in pediatric patients. We have a question here that's asking, is this effective for young adults and adult patients as well?
So I don't know if I mentioned Optune specifically, but again, that is another way of delivering the radiation and therapies more regionally. So I don't have a large experience with that.
Dr. Penas-Prado, have you ever experienced using Optune, or is that something that's available for medulloblastoma adult patients?
No, it's not used for medulloblastoma. The location of the tumor is not favorable for that type of treatment. So it's not a tool that we use for treatment of patients with medulloblastoma.
Thank you. And similarly, just talking about radiation in general and more targeted radiations, it can be confusing when there's so many different options for receiving radiation. Can you talk about what are the most common forms of radiation that are used for medulloblastoma? Dr. Penas-Prado, you can start from the adult experience, and Dr. Ruge, if there's anything different for pediatrics, please feel free to jump in.
Sure, and I think it's going to be actually very, very similar. As we mentioned earlier, for patients who were just diagnosed with the disease, for both children and adults, the type of radiation they receive is called craniospinal, and that means involves the entire brain, the entire spine, and also a higher dose is given to the area where the tumor was located. And that can be given in two different ways, with a type of radiation called photon radiation or a type of radiation called proton radiation. As Dr. Ruge explained, the benefit, the advantage of proton radiation is that the peak of radiation is delivered right inside of the nervous system, and the radiation beam doesn't go through the entire body. So that helps preserve and avoid toxicities to other organs of the body that do not need to be radiated. And that applies to both children and adults. It's a type of radiation that we often consider for adults. Other types of radiation, like gamma knife and more focused types of radiation, sometimes they have a role, but that is usually in the setting of recurrent tumors. Sometimes when a tumor is finding its way back, we always consider different options. We look to see if surgery makes any sense, if additional radiation makes any sense, or chemotherapy. And sometimes this type of focused radiation may be useful for certain situations where there's a small amount of tumor visible on a given spot. I have to say, medulloblastoma oftentimes comes back as a disseminated disease. So being very, very focal with treatment is a very special situation. You really need to analyze each case to see if that is appropriate or if it won't be sufficient. So it's something to discuss carefully with the healthcare team.
Thank you. Dr. Ruge, did you have any more insight you wanted to share on radiation?
No, you know, the challenges of radiating a 3-year-old are so that some of the studies for medulloblastoma are looking at hyperfractionated radiation, shortening the course of radiation in certain subsets, which is good. And at our center and other centers, the development has been in distraction techniques, using video cameras and things that the kids can actually watch, so they don't have to undergo sedation during their treatment. So there's a lot of things that for pediatric, depending on the age of the child, some unique features for radiation. But I think really the proton therapy has been sort of a huge advance, and particularly it seems to be just it's as effective in the outcome, but minimizes the long-term some of the long-term problems that we've seen from the photons.
Great. And Dr. Ruge, we have another question for you specifically, and this is more for the family supporting their child. You know, some medulloblastoma patients, they may have siblings, younger or older. Do you have any advice for parents on how to balance supporting? You know, you're giving 110% for your patient, but you also want to make sure you're looking out for the sibling who's also going through so much, watching their sibling go through these treatments. Do you have any advice for those kids and those parents trying to figure out how to balance this and how to support both patient and the siblings?
Yeah, you know what, that's actually been one of the wonderful things of dealing with pediatric children, pediatric brain tumor children and other things, is that the family dynamics is very important. And we didn't touch on the support services for the child, but the support services for the parents for just questions like this are very important. I know the ABTA has a lot of resources, but I've seen it, and we've all seen it. Families that are shattered by this, divorced, you know, and also families that come together and generate and lead support groups and initiatives for their children, and set up foundations and everything. You know, everyone reacts a little differently. But yes, the amount of attention that's spent on a child as a sibling can be very problematic to other siblings. And so support groups, we have support groups for parents, we have support groups for siblings, and so they can talk about it. And Dr. Penas-Prado has brought up the social media. That's been a tremendous help as well. So siblings can talk to siblings, and but it impacts the entire family in a variety of different ways, and it's very important that those are all given.
Thank you. Thank you for sharing that insight and advice. I think we have time for one more question, and this one I'm going to address for both of you to answer. I think both of you kind of touched on some of those long-term effects of these treatments and this diagnosis, you know, how it could potentially lead to other health issues in the future and other malignant issues as well. Is it possible for someone with medulloblastoma, is it possible for them to develop a different type of brain tumor? Does medulloblastoma ever evolve into other brain tumors or something more aggressive?
So maybe I can tackle that one first. Yes, it is indeed a potential situation where we have someone who was diagnosed with a medulloblastoma years back, and then later there's again tumor, and it's not a medulloblastoma anymore, but a different tumor type. And most frequently when this happens, which is anyway relatively a rare event, it's not very, very common, but it's something that we need to keep in mind. When this happens, the type of tumors that we typically find are going to be tumors like meningiomas and malignant gliomas. And this is probably in part related to prior therapies that sometimes can change the genetic background of cells that later on in life may end up developing or giving origin to another tumor. So for this reason, we are very careful when we see a patient who's having presumably a recurrent tumor, medulloblastoma recurrent tumor. Sometimes what we decide to do is to get a sample of that tumor to make sure that it is in fact medulloblastoma and not a different tumor that will need a different treatment.
Dr. Ruge, can you share some of your insight as well?
Well, I think I support all that, what you just said, and also, you know, that thyroid cancers and also another cancer, not a brain tumor, but associated, but for the brain, the changes that go on in the MRI long term, some after radiation, meningioma is up to 8 to 10% after 20 years, but also telangiectasias and vascular changes of the brain, vascular malformations and things of the brain, stroke-like symptoms that happen. So it's very important just to underscore this need for follow-up. And we've also had late recurrences of medulloblastoma. So it's important. You can't, you know, people say after 5 years or 10 years, you know, it's still, I encourage yearly evaluations and long-term survivorship connectivity.
Right. Thank you so much. Thank you both once again for your insight and for taking the time out to share your expertise with our audience. So that is all the time that we have for questions today. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers through their experience. For more information about ABTA's programs, events, services, please visit ABTA's website at abta.org. Email us at info@abta.org or call the ABTA Care Line at 1-800-886-2282.